Our keynote speaker for this morning is Dr. Gary Gilliland. In January of 2015, Dr. Gilliland, an expert in cancer genetics and precision medicine, became the president and director of the Fred Hutchinson Cancer Research Center in Seattle. Dr. Gilliland, who holds a PhD in microbiology as well as a medical doctorate, spent 20 years on the faculty of Harvard, where he was professor of medicine at Harvard Medical School and professor of stem cell and regenerative biology at Harvard University. He was also an investigator at the Howard Hughes Medical Institute and the director of the Leukemia program at the Dana-Farber Harvard Cancer Center. He has earned numerous honors for his work, including election to the National Academy of Medicine in 2015, and he was recently honored with the Geek of the Year Award, which was awarded to Dr. Gilliland by GeekWire magazine for his vision of curing cancer by 2015. Please join me in welcoming Dr. Gilliland.
Thank you for that kind introduction. When I was nominated for this award, I don't know how it happens, but I looked up the meaning of geek in Merriam-Webster, and the first definition is a socially inept or awkward person. And the second one is actually the original origin of the word geek is a carnival performer, often presented as a wild man who performs disgusting acts such as biting off the heads of chickens, live chickens. So I thought, who better than me? Anyway, I think it recognizes the fact that we're trying to put a lot of time and effort into engaging technology with our tech neighbors like Microsoft and Amazon into life sciences, and we're not going to talk about that today. We'll focus on CAR-Ts. It's really exciting to have you all here. This is an incredibly exciting moment in the biology and treatment of cancer. We'll talk mostly today in my talk about CAR-Ts, which are just a spectacular advance, but as you know, they're difficult to administer. The generation of CAR-Ts is challenging. Treatment of patients with CAR-Ts can result in serious adverse events, which we're trying to understand, but treating patients with this methodology is not like falling off a log, despite the fact that we have spectacular clinical outcomes and responses. And it reminds me, being of a certain age, of some of the early days of stem cell transplantation. You'll hear more about that from Dr. Applebaum, who was here at the very early days of stem cell transplantation, that the important thing is not to discover how to treat patients for curative intent, as we did back when with stem cell transplantation. It's that you have to get it out into the community. If we can't ensure that there's access to these treatments, then we've failed. It doesn't matter how good they are. And we're facing some of the same kinds of challenges we did in the past. And that's why it's so exciting to have all of you here today, because this is the way that we're going to make sure that we can work together as a community of caretakers to ensure that all patients across our country and hopefully worldwide have access to stem cell transplantation. I'm going to talk a little bit about immune checkpoint regulators and then spend most of the time talking about CAR T cells. You shouldn't be concerned that I have no idea how to advance the slides. Thank you. Dr. Davidson almost came to my rescue, but yeah, solid tumor oncologists are a lot smarter than those of us who work in hematologic malignancies. So you've seen some of the headlines on both the peer-reviewed literature as well as the popular press around this incredible time of advancement in treatment of cancer based on immunotherapeutic insights. Some of these actually came, as Fred may speak to, from stem cell transplantation, where we came to understand that it wasn't just the chemo and radiation therapy that we gave, but it was the donor's immune system that was of critical importance in maintaining long-term continuous complete remission or cures, although we didn't understand that at the time. And we've come to a point where we do have a much better understanding of how the immune system can help us to develop curative approaches to cancer. And that's within our eyesights. I've been provocative about saying we should have curative approaches to most cancers by 2025, and in my view, if we don't, then we also have failed as a community because it's an incredible opportunity. So after decades of research, understanding how T cells interact with tumors, we've learned a lot, including what the cancer beacons or antigens are that we can use to target, the discovery of immune checkpoints, which are, at least the ones that are being targeted now, act as brakes on the immune system that can be activated by tumors, developing checkpoint correcting therapy, and advances in the understanding of T cell biology, and some remarkable technological advances in gene therapy that allow us to genetically reprogram T cells. At our center, we've focused on immunotherapy by developing what we call an integrated research center, which involves more than 40 investigators across all of our divisions. This is led by Dr. Stan Riddell, who was instrumental in the early days of development of CAR-Ts. It's a fantastic group of investigators. And I also want to thank Stan, who provided many of the slides that I'm going to show you today and has been a pioneer in the field. So I'll start with immune checkpoint blocking activities, such as anti-PD-1 antibodies that essentially release the brakes on the activation of the immune system. And my impingement, by way of disclosure in this field, came when I left Harvard to go to Merck in 2009. And 5 days after I started, they announced, to my surprise, the acquisition of Schering-Plough. And on the shelf at Schering-Plough was what became pembrolizumab, an anti-PD-1 antibody. And based on some data that had been generated by BMS with their anti-PD-1, we moved it into bioreactors, 30,000-liter bioreactors. We're first in human in 2011. And based on these extraordinary responses, initially in melanoma, the drug was approved in 2014. So it's just light speed for drug development in terms of bringing a drug from first in human to registration within a 3-year time frame. So here's the insights around how these work, and these will be cartoon schemas, but this shows this is an actual photomicrograph of a T cell interacting with a tumor cell. But to generate this schematically, the recognition point for the T cell and the tumor cell is a combination of a T cell receptor that's specifically programmed to identify antigens that are present in tumor cells and are presented in the tumor cell on the MHC molecular complex. This engagement should allow T cells to kill tumors. And that's been a puzzle for a long time. Why don't they kill tumors? You can see these T cells sitting in tumors. In some cases of lung cancer, more T cells than there are tumor cells, and they're just sitting there. And it turns out that what tumor cells are able to do in some cases is to block the activation of T cells by expressing a ligand called PD-L1. It binds to the PD-1 receptor on T cells, and this turns T cells off. It induces a state called exhaustion. And this is at least one mechanism by which tumor cells escape immune responsiveness. So the idea behind the anti-PD-1 antibodies is to try to relieve this brake on T cells. They should be able to do everything else if they're simply activated. So the concept is to develop antibodies, and there's other strategies as well, to bind to PD-L1 and to block that ability of the tumor cell to turn off the T cells, and then the T cells just do what they're programmed to do. They know how to kill a cell. They know how to recognize a cell as being foreign based on the mutated antigens that are presented. And this has been a remarkable success, as Nancy alluded to. This is one example that led to a registration for Bristol-Myers Squibb. This actually was a combination of 2 different checkpoint blocking antibodies. One is nivolumab, which hits PD-1, and the other is ipilimumab, which hits CTLA-4. And this is what's called a spider plot, where you can see tumors that shrink in a significant proportion of patients, some patients that have stable disease, and then there are some patients who break through and escape. But it looks to be about a 30% cure rate. Now, that's not 100%, but when you consider the 5-year disease-free survival for metastatic melanoma is less than 5% with current conventional therapies, it's a spectacular improvement. And this is a response that seems to be durable. There are now patients that are many years out from their initial therapy. So a lot of work to be done in melanoma, but one of the points that Nancy also made is that this has, as for some of these precision medicine bucket trials, this has activity across a very broad spectrum of tumor types. In fact, there are very few tumors in which you don't see impressive responses. These are the same type of waterfall plots that that Nancy showed, and everything that's below the line are patients whose tumors have shrunk. I'd also say that this is not an advertisement for pembrolizumab. This is the drug that I'm most familiar with, but there are very similar data that come out of nivolumab and the Roche drug atezolizumab, which targets PD-L1. So these all seem to have what looks like roughly comparable activity. So the good news is there's a lot of competition to bring these across the line for registration paths for these tumors. And the number of tumors that are approved is growing at least a linear rate, if not a geometric rate. I read today that Pembro is approved for refractory primary mediastinal B-cell lymphoma, which is the second indication in hematopoietic malignancies. And these are monotherapy approvals. The reason that you can approve them quickly and approve them as monotherapies is because they have such extraordinary activity in patients that have refractory disease. And that means you can register on a phase 1b expansion trial without having to do comparator arms. So I expect that we're going to see many more of these approved as time. Of course, this raises a few opportunities and challenges that I'd like to highlight. First of all, there's still work to be done to evaluate monotherapy activity across a variety of different tumor types at different stages of disease. That work's ongoing. It's relatively straightforward, but it's generally going to be in a refractory patient population for obvious reasons if you're using monotherapy treatment. The other exciting opportunity is to think about how you can combine immune checkpoint regulators with standard of care and other novel agents. And this isn't just the usual oncologist or hematologist saying, if one drug's good, two drugs must be better. It's that any chemotherapy that causes cell lysis will release neoantigens that are caused by mutations that all tumors have in varying numbers. And that can act as an adjuvant or a priming system for the use of immune activating agents like checkpoint regulators. So there's some very strong rationale for combining the things that we use typically to get good response rates and try to prolong those responses by activating the immune system. And then finally, the importance of biomarkers for response. We don't understand yet which patients with melanoma do and don't respond to anti-PD-L1. We have to understand that so that we can try to develop strategies for bypassing that. And there's a lot of work that's being done and a lot of good ideas about how that might work, including activation of other immune checkpoint regulators by tumor cells. But this was the basis for the approval of pembrolizumab in non-small cell lung cancer, where it works best in the 20% of patients that have high levels of expression of the ligand PD-L1, and that's part of the label for administration of that drug. The combination story is pretty interesting. I got this slide from Eric Rubin that I worked with at Merck last week. I just asked for an update on their pembrolizumab trials. This is a partial listing of them. 600 trials, 30 tumor types, more than 400 combination trials. I didn't even know there'd be 400 combinations, but apparently there are. And I called him up after he sent the slide and I said, Eric, it looks like you guys don't have any idea what you're doing. I mean, this just looks like empiric, spaghetti on the wall and see what sticks. There are, of course, better rationales than that, but this isn't unique to Merck. This is happening at all the companies that are working on this mechanism that include Roche and Genentech, BMS, and AstraZeneca, to name a few. The other good thing for academic centers, such as all of ours, is that it's a great chance for our investigators to get in and test some of their best ideas about what combinations look like. And the pharmaceutical companies, 400 combination trials and 600 total trials, that's even for a big company, that's getting up to their peak capabilities in terms of volume. So it's a great way for them to test other interesting combination models based on preclinical data that are generated by our faculty and administrators. So that's all I'm going to say about checkpoint regulators, except to say that it's a very exciting field. And this is now moving into a phase where these are being combined not just with conventional therapies, but being combined with CAR T cells. We have a trial that's running here at the Hutch that uses the AstraZeneca MedImmune anti-PD-L1 durvalumab combined with a CD19-specific J-CAR to try to think about how we can overcome resistance in those patients who don't respond to the J-CAR, to the CAR Ts that are directed against CD19. So what about genetically reprogramming T cells as another strategy for amplifying our anti-tumor immunity. There are two broad ways that you can approach this. One is to engineer in a T cell receptor that recognizes the beacon on the tumor cell. That sounds like a really great concept. It turns out to be very hard to do in practice because the T cell repertoire is nearly infinite. And even though we know what T cell sequences on the receptors are being amplified in any given patient, we don't know what it's seeing. It's really hard to predict what a sequence sees and whether it's seeing something on a tumor cell. We have a very exciting collaboration. I'm using the word we loosely, but Adaptive, which is a company that we spun out that studies T cell receptors, working with Microsoft to provide a complete catalog of the T cell antigen maps in patients with tumors and other diseases, since they amplify in response to those perturbations, and use artificial intelligence and machine learning to help us understand, to put on virtual reality glasses and say, what is the T cell receptor seeing? And once we understand that, and it may need to be on a patient-by-patient basis, because every patient's tumor has thousands of mutations, and they're all different between. It's just like a fingerprint. But if we can pick out the one that seems to be important for that patient, know what it's seeing, we can engineer that into their T cells. And that should be a truly patient-specific, tumor-specific therapy that could obviate some of the problems that I'll come back to around how we apply these technologies in solid tumors. The other strategy is to use chimeric antigen receptor-based T cells. These are basically programmed to hit beacons like CD19. I'll come back to that mechanism in a moment. It's a laser guidance system, if you will, molecular laser guidance system. And on the interior of the cell, there's a module as part of the chimeric antigen receptor that's a molecular explosive device that's capable of killing the cell and then moving on to the next cell. So those are the two potential strategies that one can use to try to re-engineer T cells to salutary benefit. You do need to amplify the cells. This is not a trivial process. We have a wonderful cell Gmp manufacturing facility, which is a challenge to manage in an academic center. They're expensive. If you're doing GMP manufacturing for a product that's going to go back into a patient, you have to have all the regulatory and compliance issues in place. But this is the strategy. It takes about 14 days. Now we may be able to get that down to 8 or 10 days to walk through this process before we give the cells back to the patient. This is a movie that's kind of cool. If I can get it, I have to figure out how to make that work. Yeah, thank you. So the little highly refractile objects are T cells, little tiny circular things, and the longer sort of spindle-shaped cells are tumor cells. And this is a time-lapse photography of CAR Ts attacking and engulfing. It's just astonishing, really. This goes on for quite a while. I could watch it forever, but why don't we... and then they can move on and go on to the next cell. So thank you for booting that up for me. So this is a strategy that can be done fairly quickly. We're nearly uniformly successful in harvesting T cells from cancer patients with leukapheresis. It's about a 90% success rate, which is pretty good when you consider the complexities of the process and that some of these patients have been immunosuppressed for long periods of time, and that we have highly reproducible quality, which is important as you think about commercializing these things. And we can't commercialize this. I learned that at Merck. This is something that's best done in biotech or in pharma, and that's the direction that this has moved in. So the current poster child for success are the CD19 CARs. And just to explain the strategies around how to use these in treating cancer, this shows the maturation process for B cells going from a stem cell all the way up to plasma cells and to memory B cells. And shown in green are the cells that express CD19 during normal development. The key to using this to treat cancer is that there are lymphoid malignancies that are, in essence, at the same stage of development for each of these that we recognize clinically. So the pre-B cells are precursor B cell leukemias, mantle cell lymphomas in the mature B cells, Burkitt and follicular lymphoma, and then CLL, SLL in the memory B cell context. So we can target all of these. We can't target multiple myeloma with CD19, but I'll come back to that. This is a picture of our Gmp Manufacturing Facility. It's in the subfloor of one of our buildings, and I don't think you'll have a chance to see it, but I really would encourage you to see the immunotherapy clinic if you have a chance. It's a pretty cool place. So here's some images just demonstrating some of the remarkable outcomes, and these are not the things you sometimes see presented by hematologists and oncologists of this is like the one place where it worked. This works in at least in ALL in more than 90% of patients. It's really spectacular. So this is a PET scan. Tumor cells love to take up glucose, so we can see them using PET imaging with 18-fluorodeoxyglucose. And we're giving a dose here of 2 × 10⁵ cells per kilo, and you can see the dramatic response at day 37 after completing the infusion. And I'll come back to why the kidneys still seem like they're lighting up, but that's likely to be T-cell activity that persists in the kidneys over time. I'll show you an example in a moment. One important thing about the CAR-T dosing is that we do this differently here than other groups that work in this space. There are 2 FDA-approved drugs now. One comes from Novartis, one comes from Kite for lymphoma. It's CD19 positive. And their processing involves taking all the T cells as a gamish, transducing them and genetically reprogramming them, running them back in, usually at fairly high doses, but something more on the line of 2 × 10⁶ or 7th cells per kilo. The approach that Stan Riddell and the group at the Hutch have taken is to subset select for CD4 and CD8 cells separately, transduce those, mix them in equal proportions, and give them back at lower doses. And the data so far is very promising, suggesting that you can give doses as low as 2 × 10⁶ without affecting efficacy, but it will significantly ameliorate and attenuate these severe adverse events, prominently including CNS toxicities that are sometimes life-threatening or fatal. This is the example about how tumor destruction, you're not sure if you're making progress or not. This is somebody that has been treated for a month post-CAR T cells, and a lot of puzzlement about what this meant or what to do with it, because when you do flow cytometry, that big blob at the top of the CD3 by CAR T plot, it's an EGF receptor marker that we use, shows that there's tons of CAR T cells. So they're there. It's like, why isn't this going away? We think what's happening, and this person actually had a biopsy, as I recall, is that these are simply the T cells that are infiltrating the tumor, and you wait 20 months, and patient's tumor-free. So you have to be patient with these, and that's also true for the checkpoint regulators. It sometimes looks like things are getting worse in the short term, so all the trials with checkpoint regulators don't even start looking with CT for follow-up for at least 12 weeks after dosing begins. Here's another example in follicular lymphoma saying that this works not only in ALLs or more conventional B-cell lymphomas, but also in indolent lymphomas like follicular. This is a person who received rice chemotherapy, which is a pretty intensive regimen that has a ton of lymphadenopathy in the neck, as you can see. And this is the response, again, after 2 × 10⁵ cells per kilo after 28 days. So really amazing technology and clinical responses. The other amazing thing about this is that the dose that we use is shown here at the bottom of a 15 cc conical centrifuge tube. It's about the size of a grain of rice. And the nice thing about this is not a drug that comes and goes. This is a living, breathing, well, not breathing, maybe respiring entity that can sustain itself once it gets back into its own body. And that's one of the fundamental differences between this approach and how long-lasting it can be. It can be literally a single dose that puts somebody into remission for a long period of time. So it really, truly is a living drug. It's a living drug that costs $450,000, so that's another issue that we need to think about. You could probably make a cost-effectiveness argument, and I'm not going to get into that today, but there are some issues around access as well with that in mind. So for conventional chemotherapy, we give cycles of drug. It comes and it goes, and associated with that, we see tumor reduction, and in most cases, for most conventional treatments, ultimately resistance will develop, at least in the metastatic epithelial setting, as shown here. The concept with the CAR-Ts or adoptive T-cell therapies is that you give one dose, you get rid of the tumor completely, the cells persist and can maintain that state of remission. Now, the cells don't always persist, so that's something we're trying to understand. The cells sometimes will become resistant, and there's some obvious examples or obvious mechanisms you might think of, which is they just choose not to express CD19 anymore. They don't need it, and then they're not targets for ablation. So the new strategies are looking at ways to combine CD19 with CD22, which is also expressed on all these cells. It'd be hard for a cell to mutate out expression of both receptors simultaneously. So there are some strategies to try to overcome resistance, and we still certainly have some work to do to make sure that all patients are treated to salutary effect. But these are the results, and these are consistent across the different investigators and companies that are working in this space. Works incredibly well in acute lymphoblastic leukemia, greater than 90% complete remission rate. And these are walking dead. These are people who have been through stem cell transplantation, have seen everything that we've got to offer, with weeks or months to live in some cases, to get on these trials. So it's really a stunning remission rate. It works incredibly well also in non-Hodgkin's lymphomas, as well as in chronic lymphocytic leukemias, but not at the same rate as it does for ALL, even though they all express the CD19 antigen. So we're working to understand better what the mechanism of resistance is in those patients that don't respond, and then trying to think about how we can obviate that. But I think this is going to have a huge impact in chronic lymphocytic leukemia. But to speak to the challenges that we'll all face, and I think the more we can work together, it's great to have done 235 patients, more than that. But a few hundred patients is great, but if you really want to understand, that's across all subtypes. If we really want to understand mechanisms of resistance, we need to work together in this space and try to understand how we can bring larger, patient numbers always helps try to address these types of issues. So I think one outcome of this, I hope, is that you go back to your host institutions and help us think about how we can collaborate more effectively together around those questions. We would like to shorten T-cell production time. There are some strategies around that. The T-cell collection is a challenge that could limit access. And we think about the commercialization, you've got to harvest T-cells on site. They've got to be sent someplace, processed, manufactured, and sent back. So there are some significant logistics that are different than you have for more conventional chemotherapeutic drugs. And there are some issues around patients rejecting their T-cells. We do something to them that allows their own immune system to recognize them and take them out. The way that we can approach that is to use CARs that are made from fully human binding domains. They're currently, some of them will have rodent binding domains incorporated. And to increase immunosuppressive therapy to try to allow the T-cells to grow out. And another key thing is this issue around toxicity, and I don't want to underestimate that. It is significant. There have been deaths. Some of it's related to cytokine storm, and we think we have ways to ameliorate that. We administer our drug in the outpatient setting, but first temperature, which usually happens within a week or so, people come in right away, and we ramp up appropriate treatments to try to minimize the cytokine release syndrome. The bigger challenge that doesn't seem to be directly related to cytokine release is the CNS toxicity. We don't really understand that. It sometimes resolves on its own. It's not temporally correlated with cytokine release, and there are some strategies to try to moderate that. But as I said, these uniform cell dosing with defined populations of CD4, CD8 does seem to largely attenuate the CNS toxicity. This is one really exciting advance. This is still very early days, but just to show a couple of places where this is going beyond CD19. One is to try to target multiple myeloma, which, as I mentioned, doesn't express CD19. And shown in red at the top is a multiple myeloma cell expressing an antigen called BCMA. That's one of the transcription factors that's upregulated in terminal stages of differentiation into plasma cells. So it's a really good target. It's not expressed on any normal tissues except for plasma cells themselves, of course, and also on memory B cells. And the results with this, these are early days, but when you see these types of signals, you know that you're onto something that's going to be ultimately very beneficial for patients with myeloma. And as you all know, it's a disease that we're doing really well with. The median survival from when I was young to today has gone from about 4 years, I think, to in excess of 9 years with the IMiDs, with the use of autologous stem cell transplantation. But nobody's cured of the disease ever, at least thus far. And I think we're gonna move in that direction with these types of treatments. So this is just 5 patients, the first 5 that were treated out of the chute. You can see the reduction in plasma cells in the marrow in 100% of the cases, which is, well, it's 5 cases, so we can make of that what we will, but it's a really remarkable reduction. And these, of course, are patients that also have refractory disease. The one person who relapsed at day 60, and this is something we saw with CD19, was due to developing a low BCMA expressing cell. And we have some strategies for bypassing that I don't have time to go into today, but the BCMA, it's not that it's not expressed, it's that it gets cleaved and shed into the circulation, so it can trap the CAR T cells and saturate the receptors. And that's mediated by an enzyme called gamma secretase. And this is an enzyme that's been targeted for years in the pharma industry because of its activity in Notch-mutated cancers and other Notch-related diseases. So there's some good drugs out there that we're taking into clinic to combine with BCMA. We have a trial that's ongoing for that right now to see if we can overcome that initial resistance signal. But boy, is that a spectacular response. We also are trying to think about solid tumors, and these are challenging. The main issue is that it's hard to find an antigen that's expressed on solid tumors that isn't expressed someplace that's kind of important for us as living human beings. So you'd anticipate there could be serious toxicities associated with that. We like the idea of using TCRs, but that's going to take some technological advances. Those will come, but these will be patient-specific. And an HLA restriction could pose a barrier for broader applications. We also think that sooner or later we're going to encounter T-cell exhaustion. This happens normally. We have exhausted T-cells running around that recognize all of our viral antigens like CMV and EBV, all the things that we've got, HSV, in our, at least some of us have in our system. So we do think that that's something we're going to have to think about addressing. One other point to make around adoptive T-cell transfer, and Fred may allude to this as well, this was actually first pioneered in, at least to my knowledge, in marrow transplantation in patients with CML that had relapsed after stem cell transplantation. And the observation back in, I think it was the mid to late 90s, Fred will correct me, was that you could just give the donors T-cells and nothing else, and you could induce remission in CML, which is one of the pieces of evidence that the immune system's quite powerful at eradicating these responses. And I think had it not been for the advent of Gleevec, it's plausible that that would have moved into standard of care treatment at some level for patients with CML. But we also know that there are tumor-infiltrating lymphocytes that we can isolate and expand from patients that have cancer, in addition to these strategies around re-engineering the TCRs and the CARs. So if you do whole genome sequencing, and this is work that was done in Stan Riddell's lab, you can find tumor-reactive T cells, and you can identify T-cell responses to oncogenic driver mutations, which is a pretty good place to start because we know they're important, we know they're there. But it suggests that if you can understand what the other neoantigens are that may have nothing to do with tumor pathogenesis or progression, that you might be able to use this type of a strategy to treat patients to good benefit. We're also trying to target one specific antigen that's highly expressed in ovarian, lung, and triple-negative breast called ROR1. And this is expressed in some places normally, including heart, but there have been a lot of preclinical studies, including studies in non-human primates, that suggest that this is a safe mechanism for CAR Ts. And we now have a phase 1 trial that's being used to treat people with refractory triple-negative breast as well as lung cancer. And you can see in brown the immunohistochemical staining of these tumors for ROR1. Nancy mentioned the Bezos Family Immunotherapy Clinic. It's a very cool place. It does seem like a little bit of a throwback to the early days of bone marrow transplantation. It's a specialized unit. Everything comes to the patient. There's beautiful clear line of sight from all the nursing stations into the rooms. We have capacity to run, we have lab on the floor, can do interventions. and do what Nancy and her colleagues in breast cancer and so many solid tumor oncologists do, which is to really bring a multidisciplinary team together to the patient instead of having them traipse all around the SCCA trying to figure out where they're going to get their blood drawn. So it's a really cool place. David Maloney is the medical director for the clinic, and you'll hear from him later today. But he said his patients, one of the patients when they came into the clinic said, "This is really cool. It looks like an Apple store," which it kind of does. But this is actually one of David's patients who is treated for refractory lymphoma. She's one of our spokespersons for the clinic. Anyway, I'd encourage you to see it. It's really neat. And I also want to thank both the patients that participate in these studies. Of course, it all starts with them. That's what we're all here to try. Who we're trying to help. But we've got an amazing team of people that are working, at least in the malignancies that we're beginning to treat so far, with CAR-Ts, including Damian Green of myeloma, Brian Till and David Maloney treating leukemias and lymphomas, Sylvia Lee, who treats melanomas and lung cancer, and Seth Pollack, who's a pediatrician treating primarily sarcomas. So thank you. I really appreciate your attention. And thank you again for coming. It's just great to have you here. I'm excited that we've got such interest in thinking about how we can do this and work together.
Thank you, Gary. We would like to invite the audience to ask Dr. Gilliland any questions. I have one while we await the others. As the president, Fred Hutch, we thank you for doing this, but we also have a question as the winner of the Geek Award. How did they get those pictures of the cells eating the tumor cells? That was a very exciting picture.
Yeah, it's time-lapse photography, and it's just really co-culturing cells. It's standard phase microscopy, and you just have to time it. It does take some time for that to happen. I'm not sure what the time frame is. It's probably about 24 hours, I would guess. But yeah, it's just a movie.
It's very cool. Any questions? Thank you, Dr. Gilliland.
Okay, thank you.